We have some people. The meeting is recorded, by the way, so that the Huracan centers will be able to access in any case. Just welcome everyone. You know, all of you probably know now that these are monthly meetings which we hold just to try to harmonize our clinical practices. So we are focusing exactly on specific items which may be a subject of discrepancy among Huracan institutions. You know, Huracan institutions in theory are those institutions in Europe which were selected by their governments to take care of rare cancer patients. So, I mean, I see this as a kind of service to the community as long as we succeed in improving the harmonization of our clinical practices. And today, you know, the subject is a subject of discrepancy also today between, in particular, the US and Europe. So the duration of the adjuvant therapy with imatinib of high and intermediate risk GIST. You know that these meetings are completely free discussions. So just to give 1 hour, 1 and a half of time to free discussion among us, among Huracan institutions, with some kind guests from America and also Asia Pacific who wished to contribute in an attempt to improve the harmonization of clinical practices, not only in Europe, but globally. So there is just one very quick talk by Prof A Le Cesne, who will recall us the results of the IMADGIST. We all know these results, but just to have them recalled by Axel, and then we will discuss freely. So Axel, please, if you want to start.
Okay, many thanks, Paolo, for the invitation. It's a pleasure to share with you the results of the French sarcoma group IMADGIST trials, the randomized study comparing in adjuvant situation 3 versus 6 years of imatinib after resection of GIST at high risk of relapse. These results have been already presented in Lugano rare tumor 1-2 months ago, and refused by us committee due to this fact. Anyway, it is a life. So as just mentioned by Paolo, adjuvant imatinib for 3 years is a standard treatment after complete resection, but a large proportion of these patients relapse after the end of adjuvant imatinib. So the question of the study is whether more prolonged duration of adjuvant treatment by imatinib would be useful, or if prolonged use of adjuvant imatinib beyond 3 years may enable to reduce the risk of GIST recurrence. So the patients are randomized after 3 years of imatinib for patients underwent an R0, R1 resection, and with a high risk of recurrence means there is a stratification between 35% to 70% of risk versus 70% of risk. So the patients are randomized between continuation of imatinib, 3 years more, versus interruption. So it means patient received or 6 years of adjuvant imatinib versus 3 years. And of course, after interruption in both arms, in case of relapse, imatinib is reinduced. So here you have a summary of the main inclusion criteria. So risk of recurrence more or equal to 35%, R0, R1 resection. Patients have to receive at least a minimal dose of 300 or 400 milligrams daily dose for the 3 first years of adjuvant imatinib. And of course, non-sensitive mutation to imatinib are excluded. So the primary objective is the disease-free survival. Then overall survival, safety, time to imatinib resistance, rate of objective response after introduction, and quality of life, not yet reported up to date. So we have defined a study with a hazard ratio of 0.462 to try to have a 15% improvement in the 3 years DFS from 75% in the imatinib discontinuation to 90%. And so we make an analysis after 33 relapse, and the first patient was included in December 2014, and the last in April 2023. And at that date, in September 2023, we observed 43 events. The patients are well balanced between the two arms in terms of gender, age, size, tumor size, mitotic index, risk of relapse. Of note, there is very few patients randomized, maybe wrongly, less than 35%. And tumor rupture, identical between the two arms. So here you have the mutational status. The vast majority have a mutation of KIT exon 11 in 83% of cases, 84%. Very rare primary exon 17, exon 13, some exon 9, and of course also some imatinib sensitive mutation on the PDGFR alpha. Of course, the exon 18 is not a D842V. And here you have the DFS. We achieved the primary endpoint. So the curves here of the continuous arm in purple and in blue, the interruption arm. So there is a statistical difference in favor of maintenance therapy. The 3 years DFS was 87% in the maintenance arm versus 55% after a median follow-up of 55 months. So the p-value is 0.008 and with another ratio of 0.4. And we have stratified the risk of relapse. So here you have the curve of the group of patients having a risk of relapse between 35 and 70%. And here more than 70%. And I want to show you what is maybe the future in this very high risk population. Here, when you stop, even after 6 years of imatinib, patients continue to relapse according to what we already seen after 1 year, 2 years, 3 years of imatinib. So it means these patients are virtually metastatic, and if the patient relapse, whatever the duration of imatinib, the patient will relapse. We postpone the relapse, not salvage the relapse. Maybe in this group of 35 to 70%, we have not enough follow-up, but maybe most of them are maybe cured, or maybe most of them are cured by surgery alone. We don't know. Anyway, this is for the discussion. So the waterfall here, all people benefit from the maintenance. Interesting, I don't show you the slide because very few patients, but in case of tumor rupture, there is no difference between 3 years and 6 years. My explanation is maybe due to this patient have to, of course, to be considered as virtually metastatic. And when you receive 36 months of median, 36 months of imatinib, maybe there is already a resistant cells, whatever the duration. So 3 years, 6 years, if the patient develops secondary resistance to tumor rupture, these patients are metastatic. So I'm not surprised that these patients are, but it's very few, and it's only 9 and 10 patients in both arms. But we can have maybe a discussion on the tumor rupture. So time to secondary resistance when you reintroduce imatinib. Of course, there is no impact, as already reported by a lot of series, no impact on overall survival. We have not enough follow-up to see a difference. Interesting, is very well tolerated. There is only 60% of patients, around 60% of patients receiving the 6 years of imatinib, and there is only 10% of at least one temporary interruption and 2.8% of at least one dose reduction. 40% have not yet achieved the 6 years. There is some progression, but it globally is very well tolerated. And when you see here, it is a maintenance versus interruption arm. So it means the 3 years without any imatinib on blue, and in purple, the 3 more years of imatinib. So there is no difference you see here in fatigue, no difference in nausea, in constipation, in anemia. So of course you have a famous well-known secondary effect, myalgia, diarrhea, neurasthenia, and some abdominal pain, and of course, eyelid edema. So in conclusion, extending the adjuvant imatinib treatment for the conventional 3 to 6 years confirms significant reduction in the risk of recurrence. The risk of developing resistance to imatinib does not increase with prolonged 6-year regimen for overall survival, long-term follow-up needs. So the IMADGIST trial provides evidence in favor of extending adjuvant imatinib for 6 years, and I put maybe longer in very, very high risk GIST. So many thanks.
Thank you, Axel.
We can discuss.
Thank you, Axel. So anyone wants to start discussing and commenting these results?
Well, it's a terrific study, Axel. I mean, it's just amazing patients to get the job done, and you know, the data here that really to me are important, which have not been looked at in SSG 18, are the data on mutation type, and that to me is going to be extremely valuable in helping me choose at least who might benefit from 3, 6, or longer years of therapy. Just wasn't available. The other thing I really appreciate about this is hopefully you'll be able to look at one thing that was missing from SSG 18 as well was disease-specific survival. There's some people who had died from other causes, and it kind of contaminated the survival assessment. So, but here, you know, people are out long enough where we really can focus on RFS. So it's just a cornerstone. It'll become a cornerstone for what we do for adjuvant treatment, no question.
A few days ago, I speak with Peter Reichard, and so you know there is another ongoing trial, randomized 5 years versus 3 years. So maybe the data were mature next year. So maybe it will be interesting to pull the data between the French and the Scandinavian German trial to have more information, more people, more data. But clearly,
like those tumor rupture data, for example, yes.
Yeah. The future is really, if we increase the duration of imatinib, to try to define who patient benefits adjuvant imatinib comparing to those maybe by surgery. There is a plateau at 30 or 40% of high-risk population, not maybe more than 70, but between 35 and 70% of risk of relapse. Some patients are cured by surgery alone, and so the future is to try to identify who are the patients considered are virtually metastatic with no radiological GIST, because if we move for 10 years or lifelong, we have to identify that. So maybe there is a poster in ASCO on the cDNA after maybe not a prospective trial or a retrospective trial, if we have the sample to maybe validate the concept of residual DNA after resection of localized disease. Try to find those patients who need imatinib in adjuvant.
Yeah, I can't imagine you would have grabbed too early. Actually, we didn't really start doing circulating tumor DNA in 2014 when you started this trial. So it's that's going to be a really good question for the future. That's for sure. I agree.
So because I guess that the problem of European centers may be Sorry, we have some noise. I don't know. Okay, okay. It's I mean, the main problem for European centers might be which evidence would be needed in order to change standard practice. On the other side, I mean, in the US, many centers are already going on longer than 3 years, at least in some patients. So I would like first to know from US centers what they believe about this. I mean, why you believe that the degree of evidence which is available today is enough to do more than 3 years, and then we may switch to Europe and try to see what is the point of view of European centers. So any of our US colleagues wants to comment on this?
Yeah, Paolo, this is Shreyas. So it's always nice to have some evidence to back up your beliefs or your thought process. And I was going to make the point that I think the practice may be different in different parts of the world for various reasons. I think in the US, at least in our neck of the woods, since imatinib became generic and coverage has not been a huge issue, and there are discount pharmacies that can dispense it at a cheaper price and stuff, many practitioners, and I think my colleagues on the call will chime in, but many practitioners have just accepted the logical fact that, as we say in Texas, if it ain't broke, don't go fixing it, kind of thing, right? So if the disease is stable, microscopic, has not recurred, and the patient's tolerating imatinib well, at least for risk estimates that are in excess of, I would say, at least 50, but certainly greater than 65%, many practitioners just choose to keep patients on imatinib lifelong. I think reasons to discontinue would be true intolerance. That happens in about 5 to 10% of patients, maybe. And they will discontinue regardless of the risk, right? I think you may end up having to because the quality of life is poor. And then there is true progression or resistance where disease develops. So for us, from a practice-changing standpoint, it may not be that impactful, but having evidence to go support the recommendation is always helpful. I think Axel's survival comment is very valid, that the metastatic disease patients, we know their median PFS is around under 2 years, right? So not surprising that 3 versus 6 didn't make a difference, because I would guess majority of those patients may well have progressed before even getting to the 3-year mark, or certainly at or soon after, right? And I think the OS may take a long time or may never show benefit, because we have multiple subsequent lines of therapy, right? It's the composite endpoint that gets contaminated by post-trial therapies. And so OS or not, I think my perspective would be that disease-free survival improvement is relevant and important. I think if we can keep the cells from developing resistance and becoming macroscopic, I think that's a true advantage. And the other agents available all have some increasing level of toxicities, right? So if we can maintain the patient on imatinib for as long as possible, that would certainly make sense. So anyway, that's my perspective, but I'll yield to my other colleagues, see what their perspective is.
So I see Susanna, and then Andre, and then Vinette coming to Europe.
No, so I just thank you. I just want to I want to completely agree with Shreyash. For me, I was fortunate to see you present this data at ESMO and Lugano, and since then, I have told many of my patients, see, there's more data to justify what we're doing, because I do just tend to keep people on indefinitely. It's well tolerated, particularly high-risk people. I'm sort of working under every study we've done that shows something that shows the further duration of imatinib is longer, people do better. And so just extending that more broadly. So for me, I agree with what Shreya said. One of the things I thought was interesting on your curves, though, that I think would be that I look forward to learning more once you have mutational data are two things. One is that your curves split very early on, whereas in the 1 versus 3, the curves were pretty similar until imatinib was discontinued. But the 3 versus 6 suggests that early split, that there may be in some clinical or biological driver differences, maybe mutational differences that are contributing. For me, that doesn't change the overall conclusion, but I thought it was interesting. That was one. The other is that for your 3-year arm, you do plateau with the numbers are small, right? Like, so you might have 8, 6, 4 patients at risk that are a few years out from discontinuation that have never progressed. So I think one of the things that we can be challenged with is how do we identify those patients that won't recur? It's going to be a very small number. We're talking like maybe 10% of the cohort, but it'll be interesting to see if there's something ultimately that can be identified about that very small group. But really, thank you for doing this, and thank you for letting me validate this to my patients, just as Shreya said.
Andrew?
No, I agree with what both Shreya and Suzanne said, and I think that is a lot of the practice in the United States as they described it. I think it's a terrific study. Thank you for sharing it. I was a little coming back to those curves though, just so I understand them properly. The randomization happened after 3 years on imatinib, but the curves were presented from when they started imatinib. Is that correct? Or from the randomization point?
From the randomization.
Randomization point.
The curve started from the randomization.
Yeah.
Is
All
that-
patients.
All right, I misunderstood that. I apologize.
So the time 0 on the curves is when the 3-year group stopped.
Got it. Okay.
Okay.
Thank you.
The two curves of the PFS start at 3 years of imatinib.
Okay,
Yeah.
I didn't fully appreciate that. Thank you.
Yeah, but that tail you're describing, Suzanne, I think reflects the that it's not 100% risk of recurrence, right? I mean, even as the hypothesis was, it was 70% risk of recurrence, and it came out to be about that anyway, right? So we do need a more refined tool to tell us about. I mean, rather than just the 3 features we usually use to tell us about the risk of recurrence. The other comment I had, which I'm sorry if this is stating something that's very obvious, is just the the patients were selected for being able to tolerate imatinib before they were randomized to discontinue. So I mean, I think it's good to show that there's not longer term toxicities that emerge that led to discontinuation or a higher risk of discontinuation. But I would say in my practice, we've been essentially doing lifelong if tolerated, as Shreya's described. But aside from those people who discontinue because of intolerance, it's really unusual to see recurrences occur. And so even in your curves, though, you had some recurrences even in the 6-year group, if I remember correctly, before they stopped. Yeah?
Yeah. Somewhat.
So I mean, it's curious that that's happening too, because it just seems like that's a pretty infrequent event. But anyway, it's a great. Thank you for doing the study. I think it is supportive of, does make you feel better when there are data that come out afterwards to support what you've been doing empirically.
Thank you.
So, Vinette?
Yeah, thank you, Axel. I think these are really interesting data, although we still adhere to the ESMO guidelines with the 3 years and don't continue. I always have a bit of difficulty if you see that the OS curves completely overlap, and this is what we see, of course, in the adjuvant studies in GIST. And my question is, the fact that we want to proceed with it, is it all due to the fact that from all TKIs that we have, imatinib is still the best tolerable drug? Would it have been sunitinib, I think then the appetite to continue maybe would have been different. What is your idea about that?
I heard you very with difficulty. The question is?
Well, my question is, if you continue with imatinib, you do it not because there's a difference in overall survival, but because it's a quite well tolerable TKI as compared to the ones that you use in second line and higher.
I think for a patient, it's always better to have a free of disease. When you make a CT scan continuously in adjuvant situation, the patient is very happy to see normal CT scan, normal CT scan. When you relapse and you have nodules, it radically changes the psychological level for the patient, which became clearly metastatic. So
but we know now that there are more patients metastatic than we can see, to be honest with you. But anyway, I agree that the CT scan is the golden standard, although we know better, based also on these data. And the question is, you are saying it's well tolerated. We all know that if patients come off from adjuvant imatinib, they're all very delighted that they feel so much better. So I think our interpretation of fatigue is really not the one that is what these patients are telling us.
Yes and no in it, because you know there is an ongoing trial also in France. We randomize patients after 10 years of imatinib in advanced disease, and we include every week new patient, and some patients refuse to be randomized to an interruption arm after 10 years, because 10 years, I agree with Shreyas, it is a select, or it is Andy mentions, it is a selection of patients who tolerate very well imatinib. After 10 years, they have completely forgot the life before imatinib era, and so the patient asked me why I stop. I want to continue every day like an anti-hypertensive agent. So
yeah, but this is what Andy is saying. You select the patients who can tolerate it, of course. And if we are able to find something for their muscle cramps, I think everybody would also love this drug. But well, I think the most important message I take, at least in the Netherlands, is that there is more room for shared decision making now that imatinib has become also not such an expensive drug. So that's really very helpful to see the data. So thanks a lot.
But in your clinical routine practice, I think you see some patients who desire to continue imatinib after 3 years for high risk. Is correct or not? In your no? They want to stop?
We don't get the question, but it's maybe because we anticipate with them that they get it for 3 years. It's just what patients, well, meeting expectations, isn't it? If you explain someone it's for 3 years, then they think, oh, wow, then it's the end point and I'm cured. Yeah.
Bob?
Yeah, to your point, Vinette, you know, you can rescue nearly everybody who goes on, you know, who goes off and progresses. We are catching people with metastatic disease after adjuvant therapy earlier compared to, you know, obviously the earliest studies. So I mean, the data I take away here are, you know, the ruptured patients. They are basically M1 disease. Keep them on treatment. I have the same issue with rectal cysts as well. They all seem to recur if you take them off adjuvant therapy, or very, very high percentage. Maybe they're already in that 75% group. So I like that idea of shared decision making. There are some people who are, you know, flying through and have wanted to stay on. Bob Benjamin, you know, I would want to say it was already 20 years ago plus, said, you know, well, I'm just going to, after the first adjuvant trial of just 1 year of Gleevec by Randy Mateo was the 9,000. Just give Gleevec forever. And you know, once again, Bob was right in many respects. But the fact that people do have you know, some side effects and fight their way through is you know, makes it a good point of discussion at least at the 3-year time point, if not later on as well. The data I'd like to see also, if you have that, is how many people did not make it to that 3-year randomization because they went on a lower dose of imatinib below 300. It may be very hard to scrape together that information, but you know, if you ended up on just 200 milligrams of imatinib, maybe that's just what your body tolerated, and would they have gotten the same benefits? So there's another nuance that would have been interesting. But I do like this idea of joint decision making. There are people who fly through, have a number of folks who have been on for now, 10 and 15 years, and they are definitely not stuck.
I see Maria Pantaleo.
Hello to everybody. So thanks, Axel, for this study, and thanks, Paolo, for this discussion. I just want to know, Axel, can you tell us something more about the patients who immediately relapse after 6 years? For example, there are some particular characteristics to help us in the identification
we have not
of
yet
this.
analyzed in detail. The curves are. We have made the analysis a few months ago, so of course we have to wait more follow-up to try to identify those who relapse. Of course, maybe it's a particular patient with some mutational patient.
For example, the
27 patients. These patients have to be analyzed in details. I agree. It's too early.
Okay, I'm curious regarding the KIT deletion, for example. Maybe I imagine, but okay, we will wait the results. Okay.
I make a question to everybody, because some years ago, when we discussed about the most appropriate endpoint for adjuvant trials, personally, I was saying that overall survival should have been, because I mean, the two relapse-free survival curves were overlapping in the long term, and because clearly the risk is that secondary resistance could come earlier by starting earlier imatinib as an adjuvant. In the end, this I think was correct when the comparison was 1, 2, 3 years or so. Now that the comparison is 3 versus 6 or versus lifelong, I mean, as long as you demonstrate that there are no secondary resistances, so there are no more or no earlier secondary resistances, actually, it's difficult to say that relapse-free survival is not a surrogate endpoint. I mean, there wouldn't be any reason why relapse-free survival couldn't be a surrogate endpoint unless a secondary resistance comes earlier.
Paolo.
So, yeah, please.
I can add something. I don't know if you were in Lugano, but after me, in another session, we make a long follow-up of the BFR14 trial after a median of 11 years. We analyzed all the randomized patients. We have 72 patients randomized in the interruption arm versus continuation arm after 1 year, 3 years, and 5 years. And we make a follow-up and to analyze overall survival. And to answer your question, it seems that there is a difference in overall survival in favor of continuation arm, at least in the 3 years arm. 3 years and 5 years, it seems it's better to continue imatinib than to make stop and re-challenge.
Yeah, but you are talking of the advanced disease, no? You're talking of the metastatic disease.
I don't heard you.
Yeah, I mean, you're talking of the metastatic patient.
Yeah, metastatic, but it means if you consider this patient maybe virtually metastatic, we have to make a new analysis on our survival after a long follow-up. But I agree with you, up to date, in adjuvant situation, PFS is not a surrogate marker for our survival, okay. But we have to be careful maybe in the future to maybe the stop and go attitude is maybe not the best way.
No, but I mean, also in the end, the fact that there was a survival improvement in the German Scandinavian study of 3 years versus 1 wouldn't be explained by relapse-free survival curves which overlap after a while. But this may be understandable in a population whose median age maybe 65, 70 or so. So clearly, I mean, if you do a study in a population with that median age, you will see a survival improvement if relapses are just delayed by 5 years, 10 years, I don't know. So my point is that with more than 3 years of duration, I think that relapse-free survival is a surrogate endpoint, unless otherwise proven. So unless there is evidence that there are secondary resistance, there is a higher number of secondary resistances in the adjuvant population, which is not the case because you also provided the curve of time to secondary resistance in your patient. So it seems that secondary resistance is not a meaningful event in this patient. So my question for my European colleagues may be, don't you agree that as long as there is evidence that secondary resistance is not increased, don't you believe that there may be enough evidence to use more than 3 years as adjuvant treatment of these patients? Please, Lorenzo.
Thanks, Alex, for this, Axel, for this very nice presentation. I already heard it in Lugano, and I was pretty curious on a couple of things. First, answering to Paulo's question, I think that the evidence are basically growing because we had more or less the same results in 0 versus 1, 1 versus 3, 0 versus 2, 3 versus 5, and probably 3 versus 6, and so forth. Because basically, as we already was mentioned, we are anticipating the treatment of a micrometastatic disease that we are basically not able to detect by means of CT scan. So I will be more than curious to know about the ctDNA level that Axel was mentioning. Although there are some problems with low tumor burden in detecting ctDNA in GIST because of the sensitivity of ctDNA is pretty much related to the tumor burden. But anyhow, this would be very much awaited, I would say. But I think that for sure there are growing evidences that, especially for very high-risk patients, we can consider to continue. I think that what is interesting is also the data on intermediate, let's say intermediate risk patients. I don't know whether the 10% difference in mitotic count that you showed in the table that is in favor of the continuation arm might be probably more restricted to this subgroup of patients that might at least in part affected this, but also in this case I think there are some hints. On the other side, to be a bit provocative, we are considering also to treat at least maybe 40 to 50% of patients that are cured by surgery alone. So we are probably treating for 6, 7, 10 years patients that are free of disease. So probably the greatest effort should be to improve our ability to identify these patients by means of ctDNA or whatever, because my only concern is related to this fact that we are in some way treating patients that are cured for a quite long time. of course, for those ones that are at high risk, the effort is worth. For the other one, it's probably to be a bit more, let's say, shaded.
I totally agree with you, Lorenzo. There is, for me, there is two category of patients. Those who are cured by surgery alone, it don't need absolutely no imatinib, and those who have to receive maybe imatinib for lifelong. No intermediate.
Exactly. This was my point.
Yeah, of course, but this is by definition, Axel. The problem is to identify who they are. No, and do it.
By definition, for the other,
I completely agree.
in other oncology model, you can cure a woman with breast cancer. 6 cycles of chemotherapy can cure patient. With imatinib is a cytostatic, not a cytotoxic agent. So,
of course, but then we should speculate that if you keep the disease under control, even if you don't eradicate it, like with cytotoxic chemotherapy, in any case, you are preventing secondary resistance. So it's as if I mean, if you use imatinib in the advanced disease, you're facing secondary resistance. If you use it in the adjuvant setting, even if you don't eradicate the disease, because if you stop, there will be the relapse, but you don't induce a secondary resistance. So this is quite strange, no? But probably something like that, because it's difficult to explain otherwise why you don't have secondary resistance going on for 10 years of adjuvant, while you would face secondary resistance if you gave 10 years of imatinib in the advanced disease.
maybe we have learned from the hematological group when in the imatinib in the chronic myeloid, where in adjuvant situation we are more or less like a leukemia. There's very few cells. When you have a complete metabolic response with imatinib in CML, some patients are cured by imatinib alone, but 50% of patients, when you stop, even in complete metabolic response, relapse. So we have to learn maybe more from hematological malignancy.
I mean, the concept of minimum residual disease has to sort of come into play somehow, right? That if there are fewer cells and we keep them under pressure with a KIT inhibitor, then like we've been talking, secondary resistance does not develop. I think in those super high-risk patients who may almost be M1, it's very likely that the presence of resistant clones is already there. We just cannot detect it yet, right? And because imatinib will not affect those clones, it's a function of time that they will create the problem. But I think Paulo's point is well taken, that at least we can say that imatinib does not necessarily enhance, induce, or accelerate the development of secondary resistance. And if that's the explanation why those cells remain quiescent, so be it, right? I mean, it's like you said, Axel, I think not having a recurrence is so much preferable for all parties concerned than having a recurrence and having to deal with it. So that may be the clinician's excuse to continue, I guess. Javier has been on the call. Javier's too quiet. Javier.
What do you think, Bir?
I don't know. I just was thinking about the risk selection in this trial, because the threshold of risk is, under my point of view, is not very restrictive. Is smooth. Is wide. We have selected a higher risk in the Scandinavian sarcoma group trial, comparing 3 versus 5 years. This trial is really close, and the mature data will be available next year. we have randomized 250 patients, and the selection of risk was higher than 35%. Curiously, we did not use the heat map from Joensuu, curiously, but we have selected clinical pathological feature. But in any case, the risk is clearly higher than 40%, applying the heat maps. So for me, it will be very, very important, the overall survival data in the long-term follow-up according to the risk, because maybe we are able to find better results in higher risk population. I don't know. This is my point. So and ideally, obviously, as you mentioned, some of you mentioned, the data from ctDNA would be very, very interesting to be implemented in these trials, because this could add value for taking decisions in the future. But in any case, thank you very much for conducting this kind of trials, because we think 3 years is not enough for many patients. So this in some way will allow us to advance for the advice for our patients. So this will be interesting. I can't wait for the mature data of Scandinavian Sarcoma Group, and to compare the risk and the results in both trials. It's true that we, in the extended arm, we treated only 5 years, so not 6, 5. That could be also a point. So let's say.
On the other side, Javier, we know that whatever the risk, imatinib works. So in the end, if the risk is lower, you will have a lower absolute risk reduction, but in any case, you will have some benefit. No, the problem is that the degree of overtreatment when the risk is low will be higher. But we know that imatinib is not like cytotoxic and so on, so that, for example, it works more on high-grade disease versus low-grade. So we know that if the risk is 50%, you will have a lower absolute improvement. But this is not the problem. The problem is the overtreatment. Clearly, we are all concerned with prolonging lifelong kind of therapy, which clearly will overtreat a lot of patients in the absence of biomarkers, which may be today or tomorrow we will have, by the way. Andrew, oh no, sorry, Javier, please.
It's true, Paulo, and I guess in the French trial, some patients would be allocated in intermediate risk. For instance, gastric yeast with 8 centimeters and maybe 4 mitotic count are included in the trial, because the risk is in the range. But for me, maybe it's not enough. This is why I think we need data. We need to compare data, and according to the risk. It's true that the number maybe is lower than desirable, the number of patients, I mean, but yeah, it's a difficult to ascertain what kind of patients shouldn't be treated in this regard.
Andrew?
Yeah, I do worry about trying to rely on overall survival data, both because of the number of patients, the length of time, and also, as Shreyash mentioned earlier, the subsequent lines of therapy, which will have a significant impact on seeing that distinction. And I know it's a strange thing to say, because the idea of adjuvant therapy, of course, is to improve overall survival. But I think, as others have pointed out, it seems like imatinib is less likely to cure and more likely to suppress those few cells that are somehow remaining present. As we've been talking about trying to be more precise about risk of recurrence, and I think there's a lot of opportunity there to try to understand it better, whether it's inherent to the tumor cells itself or something that helps detect micrometastatic disease better, that might be separate from something we can detect in the, biologically in the tumor cells. But also, I think importantly is this question of, can we detect recurrence better at the time of cessation of drug? And is there, and maybe even now in the context of your current patients, Axel, if we could detect, let's say, circulating tumor DNA, some sort of emergent residual disease before it's gross disease on imaging, could you reinitiate imatinib at that point and not end up with resistant disease in the future? So it's possible that we can't get more precise about risk of recurrence, but we could become more sensitive about detecting emergent cells after cessation of imatinib and use that as an opportunity to reinitiate imatinib only in those patients who might need it. You have an opportunity now, I think, with your patients I hope you've been collecting the information, but as the techniques get even more sensitive, to try to detect that.
So, Angelo, your point would be to detect the disease early enough at the point in which secondary resistance is not induced by starting imatinib. As I said before, my personal interpretation of the results of the adjuvant versus the metastatic studies is that imatinib induces secondary resistance in the metastatic setting, that doesn't induce secondary resistance in the adjuvant.
Yeah, but I think Jonathan Fletcher and maybe some others have detected the resistance mutations in initial specimens using ultrasensitive techniques. So I think before imatinib.
Yeah.
So I don't think it's mutagenic. I think you're selecting for resistant cells that are just unfavored in whatever milieu of the responsive cells. So I think there's enough, well, who knows? It's theoretical, I guess, still, but because you can detect the resistance using ultrasensitive techniques on the primary specimen, I think it's still a statistical question of this comes back to the issue of debulking completely treated metastatic disease, right? Is there a benefit to that or not? Are they pre-existing clones that statistically, if you set a reduce, you can reduce the risk of recurrence? It sounds crazy in a solid tumor, but maybe that's what's happening.
And Andy, we maybe in the future we will have more information in the ongoing INSIGHT trial, where we make pre-screening of cDNA during imatinib therapy to see if we find exon 17 or 18 mutation without any progression on patient, and to try to select before the inclusion, before the progression, to select in advance patient who can be included in the INSIGHT trial. So maybe we have more information regarding the cDNA, circulating DNA of resistance mutation before the radiological progression.
Yeah, in any case, I agree that probably it's much more a stochastic fact than a biological fact. It's clear that secondary resistance, biologically speaking, will be induced inevitably, but probably, it's not given enough room to, I don't know, to proliferate or something like that. But getting back to my European colleagues, I see Bernd, for example. What do you think? Do you think that not having an overall survival benefit should prevent us from from giving imatinib, because I understood from our US colleagues, for example, they said, okay, the drug is not expensive anymore. It's well tolerated. The risk may be very high. Why not? No. So in Europe, maybe our perspective may be different. But what do you think on this?
I don't actually have any concerns about that we do not yet see an overall survival benefit. I mean, the curve is so clear that I would definitely continue it. And I mean, we are also taking part in the Scandinavian, or we took part in the Scandinavian trial, and of course, I'm pretty sure that this trial will show more or less the same results. And even if it's 5 years instead of 6 years. And so I think there is already quite a lot of evidence on the table to really satisfy the prolongation of the treatment. Or I'm not sure what other things, but that's it. Yeah.
But I mean, aside from the study, in your clinical practice, what do you do now?
Actually, we already continued imatinib for a lot of patients before we had these results. And especially, of course, again, this is a selection bias, especially in those patients who tolerated it very well. And so actually, it doesn't really change so much to our current practice.
Okay.
There is two issues, the patient issue and the regulatory issue. When you are a patient, if I show the curve to the spine advocacy group, all patients want to continue imatinib.
Yeah.
And if you present the data to the regulatory, there is no impact on our survival.
Sure.
3 years, it's enough.
Sure. Yeah, I mean, fortunately in Germany, we do not have this problem, and they will certainly pay for the drug and continue to pay for the drug even after the 3 years. I know that's not the case in all the countries, but yeah.
Maria?
But I probably think that we should continue because the curves are very, very impressive. But probably, Paolo, we need a consensus meeting. What do you think about this? Because there are some countries in Europe that need some consensus guidelines, maybe not in the ESMO Huracan guidelines. I don't know if it is easy to change the guidelines, but maybe we can manage a consensus for those who want to continue but can't continue without a consensus from the scientific community.
Yeah, the problem is so much European, I would say, because clearly it's not a problem with the US. So probably
not for Europe. No. I mean,
we would need a discussion within Europe on this for sure. Then, okay, Maria, we could find some ways by which we can help ourselves harmonize our practice. Any other comment? Oh, there is Lorenzo.
Just a quick point regarding the endpoints.
Yeah.
I think that in the end, it is not possible to detect true benefit in overall survival in a disease like GIST, where you have already some evidence that supports the fact that basically the time to treatment failure is not that different. And we have at least 3 other drugs that are pretty much active, and we just saw in Chicago a few days ago that there are other drugs coming to the field. So overall survival, to me, cannot be used as an endpoint in this disease. Probably having a deeper look in time to treatment failure, like also Paolo did in his trial, in his adjuvant trial, is a nice way to look at adjuvant treatments. Besides all the evaluation regarding secondary mutation, secondary resistance, and so forth. But in the end, I think that overall survival cannot be used in this case.
So I mean, using time to secondary resistance from the beginning or from the start of adjuvant treatment could be meaningful. I think it's clearly I mean, even this point which we tried to propose has not been validated and will never be validated because you would need survival data to do that. So by definition, you will not. But
even if it is not validated, it is a clinically meaningful one. So.
Yeah, I mean, yeah, it would be logical, no, that if time to secondary resistance is better, I mean, there's no reason why also survival should not be better, as long as the second line therapies are not, I mean, as effective as the first line, no? Because this is the problem. Any other comment? No? Okay. So I think we can close here. I mean, I thank Axel, first of all, and I thank in particular US colleagues because they provided us with some external insight on something which I think today is a matter of discrepancies in clinical practice across our centers. So I think that something should be needed. I mean, maybe a consensus effort, maybe something like that, but something is needed in order to decrease the discrepancies in our clinical practices. Okay, so thank you very much, and have a nice afternoon or a nice day.
Thanks
Thank
so
you.
much.
Paolo.
Bye.
Thank you. Thank you all.
Thank you. Bye bye.
Ciao, Maria.